Welcome everybody to AIHI Conversations. It's great to have you here. Now you would all know that this is our internal seminar series for AIHI staff and students, and also for the faculty that we have come along as well. So we have a very special guest today. We've got Dr. Matthew Knox has come to speak to us, and I'll let Tina do the introductions for that. But as you know, also we should introduce Tina as well, who's one of our amazing PhD candidates and also one of these very experienced clinician types that we have working with us, which is really important as well. So the other thing is we'll just acknowledge the traditional owners of the land on which we're meeting today, the Wallumattagal people of the Darug Nation. And we acknowledge that their traditions and customs have nurtured this land since the dream time, and we have a lot to learn from those traditions and customs about looking after community, and also the benefit of storytelling and how we can learn that way. And we pay our respect to elders past and present. Tina.
All right. So Matt and I have worked together in the emergency department for probably 7, almost 10 years now. And on top of being an exceptional emergency department doctor, Matt is also the deputy director at Wyong Hospital Emergency Department. He's also the Wyong Medical Staff Council and the clinical lead of environmental sustainability at Central Coast Health. In addition to that, because that's not enough, he's also the co-deputy chair of the Sustainable Emergency Medicine Climate Advocacy Network. So I am not going to talk any further. Matt, it's all over to you.
Morning, everyone. Thank you for the lovely introduction. Yeah, says it all. Lovely to meet you all. I understand there's a bit of a mix in the crowd and online of clinicians, academics, and people that are morphing somewhere in between. And so it's probably a slightly different audience to what I'm used to speaking to. If I accidentally bring in some sort of clinical thing that is not understood, please put up your hand and ask. I'll try not to do that though. And yeah, feel free to ask any questions as I go along, but I understand we'll have some discussion time towards the end. So the idea of this talk is to basically bring you through some of the sustainability initiatives that are happening, particularly at Wyong ED, but it's a lot of the same stuff is happening more generally as well. And it'll be sort of starting from the local projects and initiatives, and really what we're aiming to do is to collaborate and ramp that up both nationally and internationally. So I'll show you some of the efforts that we're making in that space as well. So getting straight into the local projects, one of the first ones that we did, well, I guess I'll let you know how we got into the sustainability realm in our ED to begin with, is that it was really COVID that got me really, I've always been interested in the natural world and wanting to make sure that the planet is healthy. But during COVID, the mounds and mounds of PPE that we were producing, just plastic everywhere. And it really got me thinking about waste and how we're using the excuse of treating people as a way to just not care about everything else. And I don't think we can continue to do that. And so that was where I sort of started. And just as COVID was starting to release its grip on us, was when in our emergency department, we started to have those sort of conversations about how we could, reduce our waste and make the way that we provide care to be a bit less harmful to the planet, because about 7% of carbon footprint of Australia is from healthcare. Overall in the world, it's probably about 5%. And if healthcare worldwide was a country, it would be, I think, the 5th largest emitter, which is probably something that a lot of you guys know already. But basically, so that was the sort of start of us thinking about that in our emergency department. And this Baxter PVC recycling program was the first one that we kind of did. We chose that because it's a bit of a plug and play kind of initiative where Baxter, who produce the bags of IV fluids, they have a recycling program where they've got education material, they've got posters, little videos to help us with the staff. They even supply the auto bins that we use to put all of the PVC plastic into. And then basically what we need to do is to work out where to put those bins, because the people that design emergency departments don't consider that sort of stuff with any sort of frequency. Educate the staff, and then we arrange for those bins to be taken down to the, like once they're full, taken down to the loading dock, where they get taken away by Baxter and turned into things like gumboots and hoses and that sort of stuff. Ongoing, we had to make sure that we were doing some compliance monitoring. There are a few things that should not be going in those bins, like the metal bridge at the top of the oxygen mask, as well as the little bit of hard plastic that's there. But we've now got like a little core group of people that are generally just checking in those bins, and it's generally pretty clean stuff, so you can grab stuff out that's not supposed to be there. And so far in our local health district, in the last year, we've diverted 1,400 kilos of waste from landfill. So that was a really good little project to sort of begin with, because a lot of the legwork had been done already. And I noticed that with that program, people were interested in sustainability in healthcare. And so the next thing that we did was something called Gloves Off. Now, there was a group of people. This started at Great Ormond Street Hospital in the UK, where they did a Gloves Off program, and they identified, it's basically an education project to tell people when they should and when, so that every clinical interaction, they can basically decide if there's going to be a risk of body fluid exposure. And in that case, absolutely, you should be wearing gloves. You need to protect yourself. But we also see that people are using gloves to make beds with clean sheets or push wheelchairs. And it's an ingrained habit in the emergency department as well, but hospital generally. And there's published data that 40 to 50% of glove use is unnecessary. Putting on a set of gloves as well will make you feel like you're clean. You therefore have touched a thing, and then you don't do hand hygiene because you're wearing gloves and you feel clean, and you go and touch other things. And it's a really good way to transfer infections between patients in particular, of course, which we're worried about, and that causes transfer of things like MRSA and other difficult to manage infections. So yeah, we saw the addressing our unnecessary use of gloves as a way to also improve our hand hygiene compliance. So there's a few different sources of data. There's obviously procurement data, which is obviously like when we're ordering the gloves, and it's funny, you would think that that's an easy bit of data, but I'm sure we all know that data can be difficult. And then there's on-the-floor auditing as well. And we already had the infection prevention and control people coming around the emergency department doing on-the-floor auditing for hand hygiene compliance, but we just added an extra thing in as, are they using gloves, and was it a necessary use of gloves? And so we found in our emergency department, in 1 year alone, we were using 1,072,000 gloves, which is bonkers. All right. And if we consider that 40 to 50% of these are unnecessary, then maybe 500,000 gloves unnecessarily used in an emergency department, and that's just our ED. So we decided to try to change that, and you can see the launch day in that photo where it's amazing the skills that some people have in baking cookies. I did not bake any of that stuff, which is good because that made it good quality. So yeah, we did a big launch day. We were in the back of the emergency department. Basically, you educate, then masticate, provide them with food. Any good education thing in the hospital should have food. And what we found is that we were able to, over a year, do an absolute reduction of about 15% of our gloves. So we saved over 160,000 gloves, which is really good. Nearly half a ton of landfill, a modest amount of money was saved, just over $6,000. And as far as the carbon footprint of those savings goes, it was the same as driving a petrol car around Australia, like a whole trip. What we also found was that we were stubbornly hovering at around about the 75 to 80% mark of our hand hygiene compliance. And then after the Gloves Off initiative, we've gotten over 85%, which is our benchmark, and we've stayed there, which is really good. I think one of the really useful things that came out of Gloves Off was that naturally after this, we kind of formed this Sustain ED group, and they're now a really active group doing multiple other projects, and it really raised the profile of sort of sustainable healthcare and becoming stewards of our resources. So, you know, it's great to have all of those savings of those gloves, but really it just multiplies when you actually end up with an interested and active group. So the next thing that we did was look at our disposable tourniquets, and there are some items that are on the market that are reusable tourniquets. I mean, technically, the tourniquets that we use are these like elasticated fabric with a plastic clasp, and the device itself is capable of being used many, many times. But what you do is you put it on someone's arm up near their axilla, where all the MRSA lives, and then you do something to compromise the integrity of their skin by putting a needle through there. And if you kept using that tourniquet, you would be moving it from person to person and transferring those bugs again. So those disposable tourniquets, those fabric tourniquets are not able to be cleaned, and therefore you can only use them on one patient. Now, people worry about all that waste. And so we did see that those disposable tourniquets, uncleaned disposable tourniquets, were being used across people, and that's really not a good place to be. So with this Tristel, well, obviously I'm not being paid by any of these companies, they made this silicon-based reusable tourniquet. There is another one on the market now that is by Haynes, and it's that sort of clasp is exactly the same sort of clasp as the one that we're used to using. Anyway, what we saw with our procurement data with the disposable tourniquets is we were using about 4,200 tourniquets a month. And so that was costing us $38,000 a year and producing 1,800 kilos of landfill just with those disposable tourniquets. That's not including all of the concerns regarding transfer of bugs and all that sort of stuff. I mean, obviously, it's easier to make those sort of calculations rather than attribute a hospital-acquired infection to a particular tourniquet. So what we ended up doing is buying 300 of those reusable tourniquets, and that was an initial outlay of $10,500. Now, the thing with the Tristels, and again, I'm not sure about the Haynes yet, but the Tristels can be used like 10,000 times. And so it takes about 4 months for us to pay off the initial investment of the reusable tourniquets. But then after that, you're saving money, and after using that on one patient, they're cleanable with just the Clinell wipes. So our initial model was that we were giving each clinician that is able to do phlebotomy or bloodletting or cannulation, they all had their own tourniquet, because I really wanted to promote the idea that these are not disposable. Please own this thing, because the worst thing would be, because the reusable tourniquets have got a much higher carbon footprint, are far more expensive than those disposable ones. So we don't want people chucking them out. And what we found sort of pre-launch, you know, an average of 4,200 or so tourniquets of the disposable tourniquets a month. And then after the launch, that first month in January, went down to 500. I was like, sweet, people have really gotten onto this thing. Then we found that it's sort of crept back up again, because the fabric tourniquets can't be used. The reusable tourniquets can't be used in every clinical situation. They're a bit tough for little kiddies and stuff. So we still have to have the disposable fabric ones around, and people were just kind of going with what they know. Interesting sort of learnings about culture. So now we've banged on for half a year with people owning their own tourniquet. So now what I've done is basically told everybody, bring in your tourniquets, we'll just have them on the trolleys and have them there to be shared. And then I'm just going to take away all of the other tourniquets in areas that they're not required, apart from like pediatrics. So hopefully now we'll be seeing that is reducing. But it has reduced, and we've already paid off those tourniquets, which is good. The next project that we went on to was about rational cannulation. And this is where, you know, published data really is useful, because there was already data out there to show that you know, many cannulas never get used for more than just phlebotomy. So instead of putting a cannula in, you could have just done a needle, and that's less stuff that you use. It's less, annoyance for a patient to have a device in their arm where it can get infected and cause clots and all that sort of stuff. So Esme Toth is a very enthusiastic JMO at the emergency department. She was asking me, are there any projects I can get involved in? And I sort of headed her towards this one and just basically supported her. She did all of the grunt work. Really, really impressive. And what she did some auditing on the floor and found that about a third of our cannulas are not being used for anything beyond venipuncture. And so if you add that up into a year, that's this carbon footprint of 2 trips around Australia of just those unnecessary cannulas. And what we really found is if a patient is going through our fast track section, so sort of walking wounded, not too sick, and if they're under 50, 3/4 of those cannulas never get used for anything more than just taking bloods. So what we did, we created a program, another education type of program, basically trying to promote the message that you have to be at least 80% sure that this cannula is going to be used for more than just taking blood. And obviously 80%, it's kind of taken out of the air. Who cares? You need a target. And I think it's a fairly reasonable target. And it also just promotes, instead of just doing the thing that everybody does, it promotes the clinicians to sort of stop and think, and really gives them the agency to decide, and backs them up to say that if you just do phlebotomy and that patient ends up needing a cannula, you're not going to get in trouble for that. So yeah, another education program. And what we found is that our overall percent of patients being cannulated dropped from 81 down to 68%. And so those unnecessary cannulas in fast track in particular went from 38 to 13%. Now, the timing was a bit annoying. We changed brands of our cannulas halfway through this whole thing. And so procurement data is being even more tricky than it was before. So as far as the overall savings and carbon footprint goes, we're still calculating all of that sort of stuff. But seeing that reduction has been really good. The next project was the potassium challenge. Now this was came out of an audit that was done by Jackie Coughlin in the cardiology space. She's the CN's clinical nurse consultant up there. And she was basically looking at IV potassium replacement. Now, I don't know if any of you have experience with it. Doing potassium replacement IV, it's really painful. It's a horrible thing that we do to patients. And what she found was that 61% of the patients that received IV potassium actually didn't need it to be done IV. Their potassium was over 3, so it wasn't dangerously low, and their stomach works, so they could have just had it orally. And so, the potassium challenge is a sustainability one as well, because all of that stuff is not used. The drip stand, the IV bag, the IV line, the cannula, all of that stuff doesn't need to be used, because basically we get this other stuff called Chlorvescent, we put it in some water and the patient drinks it. And so you actually can replace potassium faster by drinking it than the IV stuff, unless somebody has a central line, which is thankfully not that common. What we actually found is that we had a 15% reduction in the potassium mini bags. We were aiming for 20, but we're still working on it. But what you can see, the percent reduction depends on your start point. I think Jackie started it. I'm not expecting you to read any of these things, by the way, but the trend is important. I think that Jackie started her trend in April of 2023. Now, you can see each one of those green boxes is basically an education initiative. We're presenting it at grand rounds or doing a thing to make the awareness higher for this potassium challenge. And so if you actually started the start, is my mouse going to work on this? I don't know. The start point, if we started it around here, I mean, this is only a staff survey, this first one. And we started the presentations around about here. If we started the clock here, I think that it's a bit more than a 15% reduction. So you can see that's a very encouraging trend of that reduction in potassium mini bags. Now, I've always been wanting to tackle this nitrous problem. Nitrous oxide is a really bad greenhouse gas. It's one of the 7 that we track, and we use it in healthcare settings. It's the laughing gas. It's the stuff that labouring women can use as a pain reliever. It's a mild sedative. It can be used often by anaesthetics as a way to reduce the amount of the other inhaled anaesthetics that they're using, particularly in children. But yeah, it's a horrendous greenhouse gas. And our idea was to change it to methoxyfluorine. The green whistle is methoxyfluorine, and that's an Australian invention. And it's a far better, it still has a carbon footprint, of course, everything does, but it's 117 times better than nitrous oxide. Now, looking at the amount of nitrous that we were using, again, just in the emergency department at Wyong Hospital, the amount of nitrous we were using was producing 37,000 kilos of carbon dioxide a year, which is 7 trips around Australia. Now, it's interesting because we've got like a centralized gas system where the big tanks are not in the ED and the nitrous is piped to the emergency department to an outlet in the wall. Now, when that gas is transiting, you actually lose, it's good data published, you lose about 50, 70, sometimes even more than 70% of the gas gets just sent off into the atmosphere before it goes anywhere near a patient. So like decommissioning nitrous oxide is a New South Wales Health, I'm on the committee for that as well. Should put that on the... And we're trying to basically decommission it. If we really do need nitrous, which to me, I don't see a good role in an emergency department because we've got alternatives, methoxyfluorine. We can have just a bottle there where the valve is a lot more reliable. So basically what we did is brought in methoxyfluorine into our cupboard in the ward. It was a bit of a soft launch. I was a bit busy doing other stuff at the time, and it was easy enough to tell the pharmacist to please put this in the cupboard. And it took a couple of months. The red arrow is where we brought it in, but nobody was really using it for a few months until they realized it was there, and people had to upskill as to what it does and how to use it. And a clinician in the ED is responsible for knowing about the things that they're prescribing to a person. So it took a little while, but these breathing circuits is what I'm using to track our amount of nitrous use, because nitrous is used throughout the hospital. If I tracked just the bottles of nitrous, it wouldn't be as accurate, but we use these breathing circuits to administer the nitrous. And you can see, a couple of months of people getting to know, and then it's really plummeted down because we now realize that it's actually better pain relief than nitrous. It's a lot faster to set up. You go and get it out of the cupboard, you pour the liquid into the bottom of the green whistle and you give it to the patient, and they can do it themselves, whereas there's a lot of faff time involved with nitrous. And there's less vomiting. Even before methoxy came along, I didn't like nitrous because kids always vomited afterwards. It's horrible stuff. The problem is that it stinks. Methoxyfluorine, I don't know if you guys have ever smelt it, but it's a bit smelly. And it's expensive. It's about 50 something bucks for each of those methoxyfluorine whistles. And what we found, and again, this is only, we only brought it in September 24, and culture takes a long time to change anywhere, but particularly in health. We're finding that probably we've gone from about 35 monthly administrations of nitrous down to about 18.5, and I think that that's going to continue to go down. But if we use 18.5 as the amount that we're doing each month now, we'll be saving about 17,000 kilos of CO2, so 3 trips around Australia every year. It does, however, cost about $8,000. Now, I haven't been able to factor in all of the extra nursing time and all of the extra anti-nausea medications that you give with the nitrous, and so I think it doesn't cost that much, but we're still working on that. But of course, you always have to explain things to the people that run the hospital. I'm letting this one fly under the radar a little. I think it's worth it. $8,000 is chump change when it comes to how much it costs to run an emergency department, and it's saving a hell of a lot of CO2 emissions. Now, it also, when somebody comes in with, say, a dislocated shoulder, our general procedure is to actually bring them into resus, full monitoring, give them things like propofol, like a proper anesthetic, to make them completely asleep to reduce their shoulder. You can actually do it. I mean, it doesn't always work, but you can do it with methoxy. And so that person will just stay in a chair, upright, awake, without the monitoring, and you can get their shoulder back in. And so that's cost savings and CO2 savings with that are very significant. In America, it costs about $2,500 for each episode of procedural sedation. And you'll save that with a $50 whistle. So I think we can kind of see that this sort of sustainable healthcare is vast majority of the time it's high value. You're being a good steward of your resource, you're reducing your waste, and most of the time you're reducing your costs, which is the opposite, I think, to what people normally say for those sort of environmental things. You're like, oh, I have to spend money in order to save the planet. It's not actually the case at all. It's just, you know, we are so under-resourced in healthcare. We're always pushing to try to get more resources, more funding for staff and stuff. And if we're willingly being poor stewards of our resources, allowing things to just be wasted when they don't really need to be wasted, it puts us in a bad position to stand there and say we need more. So my real mission at the moment is to make us good. Like every time you use a thing, you stop and go, do I need to do that? And so if that decision is being made by informed clinicians, like our use of everything should start to go down, I would expect. So what I was able to do with all of this stuff going on is to put forward a business case. And through presenting the gloves off data, I met the director of finance, and I was able to just cold call him and just have a bit of a discussion. And I was able to put forward this business case to create a day a week for a senior clinician, which ended up being me, to do this sort of sustainability work, because a lot of it was being done through volunteerism, which is not sustainable in any sense of the word. So it'll be a day a week for me, and we've now just done the interviews for 2 days a week of nursing. Going to be a good little team to get this stuff done, and instead of having to do it in our own time at home. And so we are the second hospital in New South Wales to get a funded position like this. Coffs Harbour was the first one. North Shore kind of had it, but that was funded via a charity organisation. And so this is the second time this has actually been funded by the hospital, which is really good. And I'm glad that our hospital was able to be not talked into, they saw the light that this is an important thing. So this is now that we've got our little team, this is going to be our first project to go forward with. It's the Choosing Wisely pathology resource package. So doing blood tests, it costs money again, but has a carbon footprint too. And there's good data to show, well, it depends on the study, 11 to 44% of the tests that we do are unnecessary. They don't change management. So our aim is to now start reducing unnecessary pathology, and then the next target will be unnecessary imaging. We haven't started on that one. But basically at Coffs Harbour, they had a program where they were able to reduce unnecessary pathology, and in one ED they saved $500,000. So that would justify my own existence as the sustainability lead and the wage that I will be paid for that. And so from that Coffs Harbour work and and that was Brian O'Connell has done a lot of that amazing work, and they're working together with a lot of really good people at pathology to just do this, based on best practices for project management and that sort of stuff. We've created this whole package, and the idea is that we're going to do it. It's happened at Coffs. We created the package, fine-tuned it. It's going to be launched at Wyong, and then from then on, it's going to go everywhere throughout New South Wales in particular. But through other channels, we're going to try to make it more wider than that. Excellent grammar. Part of that was this letter that I made. So as the chair of the Medical Staff Council, I was able to get together with Anne, who's the other chair at Gosford, and we created this letter to basically say to all of the JMOs that the unnecessary pathology that is being done, a lot of that is our decision as the senior clinicians. We understand that, and we're going to try to reduce that as much as possible. We are part of the problem. But if you are making a decision on a blood test and you have a good clinical reason why that test is not required, you will never get in trouble for not doing a test. And I think that that's part of the reason why some of these things are done, because they're doing their blood round at the end of the day and go, oh, I better get this done, otherwise during the round in the morning I'm going to get chewed on. So we circulated this through all of the senior medical clinicians in the hospitals, and they all agreed to sign for this letter, and so hopefully as a way to change culture. So all of those things, and there are other projects being done in emergency departments, but that's a sample of the things that we're doing at Wyong. And so the Sustainable Emergency Medicine Climate Advocacy Network is the reason that we need the acronym SEMCAN. That is the network in our college, the Australasian College of Emergency Medicine, that are involved in doing this sort of sustainability work. And some of the actions that we've done is this is still in sort of process, but planetary health is becoming a major pillar of how our college functions. And so it will be used for education, and like that fundamental change is going to be happening through our college. We've been doing a bunch of webinars, and we're going to getting a YouTube series up and running as well shortly. We haven't started publishing on that, but there's a lot of work being done. Collaboratively, there's the Green ED pilot as well. I'll show you a little bit of that in just a second. And we're trying to work with other organisations like Doctors for the Environment Australia and CAHA. So this is the Green ED pilot that's come from the Royal College of Emergency Medicine. So that's in the UK. And basically this is a accreditation process that an emergency department can go through to show that they have done a lot of sustainability work, and you can get bronze, then silver, then gold accreditation. And so there's a launch now in New South Wales. There's 13 hospitals throughout the state that are getting accreditation for Green ED, and we're coming up to that time now. It's been about a year, and we will be getting some level of accreditation at Wyong ED soon. So that's a good collaboration that's happening. And we're adopting that sort of from internationally. It's going to be interesting because, you know, reviewing nitrous and making methoxy and reducing non-sterile glove use is part of silver, but we haven't gotten bronze yet. I'm curious to see what sort of accreditation will be given. And there's like reduction of cannulation is there, and you know, it's a bit of a mix. But there's lots of really good evidence-based actions that we can do, and they've got like an online portal where you put all your projects in, and they can share, and we've got monthly meetings and stuff, of course. So then internationally, there's a sustainable emergency care website that's being created. Again, a lot of that good work with Brian O'Connell and the team that he's got around Coffs Harbour, because he's like a net zero hub for New South Wales. He's created this website with his team, and basically one of the kind of issues with Green ED was that it's behind a firewall. The hospital has to pay a bit of money to get onto it to begin with. And so this one is going to be free open access as a way to just share with everybody the projects, because a lot of the stuff like Gloves Off, I lent on the work at Great Ormond Street, and also John Hunter had done a Gloves Off, so I had some resources to start with. So that's going to be the idea, is like getting it like, you're interested in Gloves Off, here's your package, and also here are the people that you can talk to get some ideas. And through that website, we're launching a global emergency Gloves Off, so aiming to do like throughout the world. There's been an Asian launch through the recent International Emergency Medicine Conference, and it's happening through other countries throughout Europe as well. And so the effect that we've had at Wyong, trying to sort of maximize that throughout the world, trying to get coordinated. And we're aiming to get sustainability to be a theme at every conference. So now going forward, what we really need is a carbon footprint for everything. That's really one of the rate limiting steps to getting all of this work done, is knowing the data and knowing where the hotspots are, and the next thing that we should be trying to address. Say, like, you know, it took me a while to actually realize how bad nitrous was. I would have attacked that a bit earlier if I had have known. We need to get funded positions like mine in every department, not only EDs, but throughout the hospitals, so that there is somebody being paid to drive this stuff. As I said, generally it'll be saving money. And we really need to get state and federal coordination with all of this stuff, and as much collaboration as possible. So that's the sort of Cook's tour of what's happening in the emergency medicine field with regard to sustainable healthcare. So thank you for your time. I hope that was informative.